Thank you.
Okay, thank you. I'm excited to be here today. I'm going to be presenting the work from our clinical team, and so I wanted to give the credits right off from the bat. Jonathan Serlin joined our group this year, and he did most of the analysis of the data, along with Samantha, who was a medical student. The clinical evaluations were done by Emery Ryan and Dr. Lopez over the last 15 years. So those of us in the field know that one of the biggest challenges is to identify scalable progression markers to track neurodegeneration. And since we've been following a cohort that's mainly Gaucher disease or Gaucher carriers, we thought this would be a good population to use to see what we could find. So our study questions were: which non-motor, neuropsychological, or olfactory measures effectively differentiate disease status and track longitudinal progression across the GBA1 spectrum? So we did this as a part of a rolling longitudinal cohort framework, which encompassed about 4 decades worth of data. We evaluated records from 1983 to 2024 of individuals who were at the NIH and identified about 161 eligible adults that had the appropriate data and assessments. Of these, 52 were Gaucher carriers, 79 had Gaucher disease, and 30 were either carriers or patients with Gaucher disease who developed Parkinsonism. 87 of these patients had more than 2 visits, and 74 were single visit. When they came to the NIH, they underwent a uniform assessment, including self-reported domains, questionnaires for non-motor symptoms, sleepiness, fatigue severity, depression, and anxiety. They also all were evaluated by a neuropsychologist with complete IQ scores, and they all performed a sensory evaluation using the UPSIT, the 40-item scratch and sniff. The analytic framework was a measure-specific baseline, where we began with the first non-missing score for that measure. The time scale was the years since the first available assessment, and we used a mixed effect model adjusted for age, sex, and education. So our baseline demographics pretty much were comparable across the 3 groups that we studied in terms of age, sex, number of visits, and education. At baseline, the individuals that had developed Parkinsonism showed differences in olfaction, sleepiness, and overall non-motor burden. On your left, you can see the UPSET scores, where the GBA Parkinson had markedly decreased olfaction. You can see that they were more sleepy and they had more non-motor symptoms. Not a big surprise. But we didn't see any adjusted baseline differences when we looked at fatigue, depression, anxiety, or IQ. We then looked at trajectories over time, and where we saw some differences over time was in olfaction, and these are spaghetti plots where we show the olfaction score each time they came when they were done multiple times. So the bottom is years. If you have a score under 36 or 34, I can't see with these glasses, but anyway, it's mild hypoosmia, and total anosmia is the lower line that you see there. So you can appreciate that olfaction is more affected in patients with Parkinson's disease, and it declines over time. We did see quite a scatter in our patients with Gaucher disease and our carriers, though their trajectory wasn't that obviously, it was sometimes up, sometimes down, maybe a trend with age is going down a little bit, but nothing like what we saw with the individuals with Parkinsonism. We actually measured that decline in olfaction over time, and we found that the UPSIT in patients that had Parkinson's disease declined about 5 times faster than Gaucher patients without Parkinson's disease and twice as fast as the carriers. I don't know why the carriers declined faster than the homozygotes, but in any case. We then looked at the self-reported scores and the IQ measures and found that looking at them longitudinally, we found that they were pretty much stable. Where we looked at group by time interactions, which was the group-specific trajectory or speed of change, and looked at whether they differed between the groups. And we found that only the upset, only the olfaction showed all 3: baseline separation, overall decline over time, and a significant group by time interaction. We then did a few secondary analyses to identify narrow subgroup specific signals. We looked at the GBA genotype, and we classified them as mild or non-mild for the most part. You can see that our carriers were about 83% N370S homozygotes. Our patients with Gaucher disease were about 45% were N370S homozygotes, 20% N370S L44P, and the carriers were about 30% carrying our patients with, Gaucher Parkinson, about 30% were N370S homozygotes. When we looked at the carriers, we found some mild variants that had a lower baseline upset. And a signal for decline didn't reach significance, though. In our Gaucher disease group, we saw no genotype-associated baseline or longitudinal effects. And in the GBA1-PD, we found some non-mild variants that had higher sleepiness and higher BDI at baseline, but their trajectories didn't differ. We also looked at family history of Parkinson's disease. When we looked at the carriers, we saw no significant differences by family history of Parkinson's disease. When we looked at the patients with Gaucher disease, interestingly, baseline anxiety was higher, and there was a steeper increase over follow-up. But I would say that a more likely interpretation is that the anxiety could reflect the psychological vulnerability of family-related Parkinson concern rather than a broad prodromal neurodegenerative effect. So in summary, the strengths of the study is that it was very much data-driven. It was a long follow-up. We used standardized phenotyping for olfaction, non-motor questionnaires, and IQ, and we used mixed effect models that retained repeated measures and adjusted for age, sex, and education. The limitations were that the data availability varied a lot by measure and visit. It was a single center cohort with not enough GBA Parkinson's disease. It was a smaller group. We did not take into consideration the different Parkinson therapies that could influence self-report measures, and the recent COVID pandemic may have impacted the upset scores. But in conclusion, the implications for tracking and progression are the following, and in some ways this was a disappointing study, but on the other hand, I think it's really important to report it so that people don't waste the number of years that we had bringing in people in for all these assessments. The accelerated olfactory decline was the most robust objective marker differentiating GBA Parkinson's disease in this cohort. Cognition and self-reported symptoms were largely stable, limiting their utility as primary or early intervention endpoints. The accelerated anxiety trajectory in GD seemed to reflect more psychological distress regarding risk than anything else. And bottom line is, for enrichment and monitoring across the GBA spectrum, objective biological markers should be prioritized over the self-reported studies alone. I do want to mention that in the course of this study, we've really only seen one person who we were following convert to Parkinson's disease. So it's kind of hard to extrapolate, and this is the best we could do with the data that we have, because we don't know, eventually what will happen. But I think we were a little bit ahead in discovering this, so we've been following our patients for a long time, and we're pretty comfortable that the vast majority don't look like they're going to convert. Thank you.